started to say a few comments about how we got here in Alabama and where we are with respect to the pandemic. It's been quite a year and a half, well, 20 months, almost 21 months now. As all of you know, this is something that none of us really expected, and yet it's really sort of upended most of the things that we do and most of the normal life that we've experienced before. I would have to begin by saying we probably weren't very well prepared for this at all. We have significant public health infrastructure needs here in Alabama. We are the most poorly funded public health agency of any state agency. We get about 7 or 8% of our funding from state dollars, and the rest of that comes from whatever other sources we're able to cobble together. As you may know, we don't even have county health departments in every state. In the past 10 to 12 years, our staff has been cut by approximately 60%. So we have about 2,500 employees statewide, less than half of where we were a decade ago. So with these sort of challenges that were coming in, we began to recognize the enormity of the challenges that we were going to be facing. As you know, it was really just the week before Christmas in 2019 when public health officials in China announced that we've got some respiratory outbreak going on, and within a couple of weeks, that pathogen had been identified. It had been sequenced. There was testing already available for it in the first 10 days to 2 weeks of January of 2020, which is just a remarkable feat. Even the first vaccine efforts were beginning at about that same time. That's when we stood up our own scientific response section here as part of our own emergency response. But we, again, faced some really significant challenges. A lot of those had to do with data. Alabama is one of only a couple of states in the country that does not collect hospital discharge data. You know, I would tell you that in a given year, our epidemiology staff tracks around 2,500 notifiable diseases or outbreaks in our state. These are typical things like a flu outbreak in a nursery school, or a gastroenteritis in an assisted living facility, or certain types of notifiable diseases that are zoonotic infections or certain types of imported infections. But about 2,500 a year is the most that we typically encounter. And as you all know, as the COVID-19 pandemic increased, we reached times when we were having more than 5,000 cases per day, 2 years of work every single day. And it was literally impossible for us to scale up and handle that, although we certainly tried mightily to do that. But doing that type of case investigation, doing clinical monitoring and contact tracing really overwhelmed our system really, really quickly. Very closely with our National Guard, for example. We've collaborated very closely with our forestry department, for example, who are great at logistics and moving things, who are great, who are located in a lot of rural areas and helped us a lot with their transportation needs. We've worked closely actually with law enforcement, as a matter of fact, because they have the ability to help us move things very quickly. Law enforcement was actually a big part of distributing remdesivir, our IV medication for hospitalized patients, because they're allowed to drive fast and because they were able to get that out in areas that we weren't able to do that. But really more importantly, we have had to learn the importance of communicating closely with the public in general. We became aware very early, something that we've all recognized now, which are the equity issues associated with the pandemic. As you know, COVID-19 has created another health disparity. It's not a new health disparity, but it's a hospitalizations and deaths among our African-American population. And we knew that we needed a lot of help in trying to communicate, to get the word out about how to protect yourself, about what to do if you need to get help. And, all these are just issues that are on top of all the other underlying problems we have in Alabama. We don't think that COVID-19 has affected our population any differently than we see with infant mortality, or with coronary artery disease, or end-stage renal disease, or a number of other things as well. Unfortunately, we have a large number of people who just don't have access to care. That's a very difficult problem for us. We're not a Medicaid expansion state, as you know, unfortunately. That creates a lot of missed opportunity for us. So we've learned to work very closely with the faith community, with nonprofits, with public officials, with local medical professionals. Frankly, we're as a state agency, in state government in particular in Alabama, we have a poor track record when it comes to dealing with many African-American communities and with rural parts of our state. We have a long history of not doing the right thing, unfortunately, in Alabama. And so we recognize that was a real need for us in of about 8 states now in terms of people who received at least one vaccine. And our African-American citizens in Alabama are actually vaccinated at a higher rate than any other race in Alabama. We feel like that message has been heard by a lot of people, and we work very hard to try to do that. So we still have a lot of infrastructure needs. We still have a lot of resource needs in spite of lots of federal money that's coming down the pipe. We don't always have access to that. We, for example, don't have access to American Rescue Plan funds right now. That's all is going to need to be appropriated by our state legislature. So we don't have access to any of that money at the moment. We're not sure if we will. On top of that, we've got this whole layer of partisan politics that's been layered over everything, which has really presented a lot of challenges to us. But anyway, I'll pause right there. To Director James, I'll be glad to answer questions. But again, I do just want to say thank you very much for including me today.
Well, thank you so much, Dr. Harris, for being here. I want to ask Dr. Frazier if he would come forward to add his comments to our panel.
Yes, good morning. Can you hear me okay?
Yes.
Great, thank you, yes, for having us from the Department of Agriculture at my desk as a state veterinarian. And I enjoyed listening to the presentation from CDC already, and certainly from Dr. Harris. We recognize that, livestock and animals, companion animals, are kind of under our observation and direction, and charged with developing disease control programs, and know that in those systems that those animals will have and should have contact with human beings. So we recognize the importance of certainly meetings like this, and developing strategies and approaches to diseases that we know about, and then looking for plans for emerging zoonotic diseases. We'll just say and add this, that from agriculture concepts and thoughts, that not only locally here in Alabama, and then domestically across the United States, and then certainly internationally to the world, that the population really most often is looking for and demanding and expecting available quality protein and a low cost, efficient, development system. And those systems of producing high quality, low cost protein will always have humans and animals at that interface. So
Ask one to please mute.
Thank you. Just pointing out that again, that the food systems will certainly when it comes to animal protein and that availability of that protein, we'll see animals and humans in contact, and so it will require us to continue enhancing One Health mechanisms to support that, not only to support that as well as the environment, to support that, but then to also look for relief of disease that could be spread from animals to humans. And then, quite honestly, one of the things that concerns us and my desk is diseases that could be spread in what we call reverse zoonosis from humans to animals. So we're excited about the presentations today. I'm sure there will be much information to come. So thank you again for having us. And my desk is the State Veterinarian at the Department of Agriculture. We look forward to the panel discussions. Thank you, ma'am.
Thank you, Dr. Frazier. We had Dr. Margaret Kahatsa, but she has dropped off. I think she did provide a video because she's in a remote location. Dr. Nashar, do you have that available for us? You're on mute, Dr. Nashar.
Dr. Nashar, you are muted.
I'm sorry. Well, I was saying that we don't have the video. She was supposed to send the video. She's currently having a poor connection. She's in Kenya, Nairobi. And so we're waiting really for any information from her. Well, I do have, I have her PowerPoint, which I can run through if this is okay. What do you think, Attorney?
If you feel comfortable doing that, I think that's fine. Otherwise, we can just see if there are some questions from the audience for our two panelists and for our moderator as we wait to see if she's going to be able to rejoin us. So I'll bring them back to the center and we can give her a couple more minutes. So are there currently any questions for Dr. Harris or Dr. Frazier or Dr. Behravesh?
Yeah, I put a question to Dr. Behravesh, which is that the WHO has put into priority Nipah virus. So Nipah viral diseases currently is a problem in the Southeast Asia. And apparently, I mean, this is spread by fruit bats and can affect pigs, and pigs can transmit the disease to human. And currently mortality is about 59% human mortality in those places. So, and there is no vaccine and no treatment for these viral diseases. And so I asked Dr. Behravesh whether CDC has a priority for this particular virus.
Yes, well, the list of 8 priority zoonotic diseases I showed earlier, those were selected by interagency partners to focus on for our One Health collaboration. We developed some specific criteria for the United States that led to those 8 particular diseases being prioritized. But the good news is it doesn't mean all the other zoonotic diseases are not also important. And CDC has a division that's dedicated to high consequence pathogens, and that includes Nipah virus. And there's a lot of work going on in the region of the world where that virus is more prevalent.
Thank you.
We also have a question in the chat for Dr. Scott. And it reads, Dr. Scott, what are your thoughts about Alabama using COVID funds for building prisons?
Well, I would say I wasn't consulted on that. Under Alabama law, our legislature has the final say in how that money gets spent. I suppose there certainly may be federal strings that haven't been appreciated yet that may affect how that works. Obviously, what we want is to be able to do our best to take care of the health and safety of our state. Our primary goal right now is vaccinating, reaching those people with vaccines that have not yet been vaccinated. We hope that we will have access to funding that will make that possible. But at this time, I think we just don't know. We don't know what's going to happen with those funds.
I have a question for either one of the panelists. From your perspective, what has been the biggest challenges in working across disciplines to respond to the current pandemic?
I would just jump in initially and just say our number one problem, for a year and a half has been overcoming misinformation. That's not necessarily a problem with working with people who want to work with us. We have a lot of people who want to do the right thing. I think most Americans, probably want to do the right thing. They want people to be safe and they want to get back to normal. But there's a huge partisan divide, unfortunately, on how to get there. Our role in public health has been to try to advise people with the very best scientific evidence we can. We have mostly found that our partners and collaborators are on the same page with us. We ultimately are not the people who make those decisions. That falls to the political class, and we try to inform them with the best information we can. I could have never have conceived the misinformation industry that we're seeing right now. I think we all recognize that we all get our news and information in our own bubbles. We like the things that we like, and we tend to gravitate towards things that reinforce what we already believe. I think we all do that. It's hard to challenge yourself by listening to people you vehemently disagree with. That's a hard skill to learn. And so because of that, we have people that simply are never going to understand those of us who speak the language of science. It's really been a big challenge.
I have a question. I saw in some news article, and that referred me to the Facebook post. There was a channel. It says WXYC TV Channel 7. It has a Facebook page, and they made a post in which they asked the following. They said, after the vaccines were available to everyone, did you lose an unvaccinated loved one to COVID-19? If you are willing to share your family story, please DM us your contact information. We may reach out for a story we are working on. The funny thing about this post that has 255 million comments and countings or something is that I have not found a story. I went many thousands of things trying to find a story like the one that they were asking for. So even though most people don't have stories to tell there is all the stories that are told are about people who are either were fully vaccinated and died, or died shortly after being vaccinated, or started having severe symptoms after being vaccinated, even though maybe not lethal, that led them to have chronic conditions and all sorts of stuff. And I thought that was very interesting. Have you heard of this?
I had a little bit of issue with my bandwidth there, and so some of that broke up. But I believe you're asking about side effects of vaccination. Is that right?
Yeah, there was a Facebook post. I can put the link there in the chat. So it was by a channel. They were asking for stories of people, for people to share the stories of family members who had refused to get vaccinated and had gotten COVID and died. And what people started sharing were stories about people who got vaccinated and then got COVID and then died, or got vaccinated and died of other reasons that were not related to COVID in a very short period after vaccination, like 4 days, 1 week, 2 weeks, sometimes shortly after the second dose of vaccine. Some say the brand of the vaccine, some do not, most do not say the brand of the vaccine. And so there are some people that are even saying that because it is so much time consuming and so much paperwork sometimes for the doctor to report any of these events, the events may be being underreported and stuff. And I wanted to know what your take was on that, because I was surprised to see over 200,000 comments, none of them telling stories of people who refuse to get vaccinated and dying.
Yeah, so I think it's really difficult sometimes to get a sense of the magnitude of risk when you're talking about these absolute numbers. I mean, please remember that we've had over 400 million doses of COVID-19 vaccine that have been administered just in this country.
Work.
Yeah, just this amount, and so particularly the VAERS data that is collected through CDC, remember, is just reports that can be reported by anyone and is not necessarily confirmed, and in most cases turns out not to be confirmed very much. But by any measurement, these vaccines are highly effective and highly protective, and people who at every age group are much safer if vaccinated than if they acquire COVID infection otherwise. We know, for example, in Alabama hospitals, between 85 and 90% of all hospitalized patients are completely unvaccinated patients. We know that virtually no one who's been fully vaccinated has died after getting COVID. Those deaths that we have seen have been in almost always in people over age 75 who had other chronic health problems, who are high risk individuals anyway, unfortunately. But even in that age group, vaccinated persons with those risk factors have a incredibly smaller risk of death than unvaccinated people who have those same risk factors. So I would just say, we have seniors and high-risk individuals who have been the target of our vaccination campaign. Again, there have been, more than 400 million doses administered. And sometimes when you're looking at a group of seniors and people with chronic health problems on the order of, tens of millions of people, you're going to have people who die contemporaneously with receiving an injection. That by no means implies causation, and I would say there's virtually no, it's not that there are no reports of death from vaccination. There are some that have been associated with true anaphylaxis, but even then, the risk of dying from vaccination is so much smaller than dying from acquiring COVID-19 infection.
So basically, probably
Jotna, I'm sorry. We have several other questions in the chat that I want to try to get to. We can come back to you in a moment. But I did want to ask some of the other questions from other participants at this time, if that's okay. This one I think is for you, Dr. Harris, as well. The question is, how can COVID-19 testing be increased in Alabama?
That's been a real challenge. We see these surges. When we have surges of disease, we have surges of demand in terms of testing. What we've tried to do is promote testing in as many locations as possible. We are now rolling out our school testing program thanks to a grant from CDC, which will allow for surveillance testing in school environment. We worked with a number of different urgent cares and walk-in clinics around the state to make sure testing is available. A lot of our federal retail pharmacy partners that have been doing vaccination are also doing testing. But I can say, in spite of all that, there's still some challenges in doing that. I had a family member, myself, a grandchild last month who had some symptoms and needed to get testing. And even being in the middle of this response and knowing what I know about it, it took 3 or 4 days to find a place where he could be easily tested. And this was in one of our largest cities in the state. So we still have a lot of work to do, but we continue just to try to find providers and locations who are able to be part of that program.
Thank you. And Dr. Behravesh, this one is for you. We only read of bat coronavirus studies in Southeast Asia, obviously because of SARS-CoV-2. Are there bat studies in other parts of the world and in the US, and what do they show?
Yeah, there are many different groups, government and academic partners doing different types of studies, looking at a variety of different types of bats. Bats are a very important part of our ecosystem, but it's a good idea not to interact with them. There are diseases like rabies you can get from a bat, as well as others. And different types of bats in different parts of the world might carry different diseases. There is a global network of bat researchers that comes together regularly to share and exchange information as well. But bats will be an important species to continue research on from the emerging infectious disease standpoint.
So our next comment kind of goes back to the issue raised by Jatna, but the former Secretary of State, Colin Powell, died of COVID-19 complications, and of course he was fully vaccinated. How does this story, especially from such a high profile person, impact the efforts for vaccination?
Well, I guess I don't know. I think, all of these stories, unfortunately, in a lot of cases, confirm people's biases, whatever they are. It's a tragedy to see anyone lose their life, and then certainly someone of his standing and stature. Makes me personally very sorry to hear that news. Again, I think in my mind, it just confirms the fact that we're dealing with a very deadly virus, in spite of the fact that we have a widely available and safe and effective vaccine. Vaccines aren't perfect either. And if for people who are at high risk because of age or comorbidity, certainly it's really prudent to, continue precautions to the extent that you can. Our hospitals and healthcare providers are doing a much better job of providing medical care to those people who are infected now. We have pre-hospital treatment like monoclonal antibodies. We're about to have an oral medication, molnupiravir, available. We certainly have, a wealth of knowledge and experience with taking care of people after they are hospitalized. And I think our providers have learned a lot about how to do that. And yet, we still have people dying every day. In the state of Alabama, we've lost more than 15,000 people in our state. I will tell you that just in 2020 alone, we lost around 7,000 or 8,000 Alabamians from COVID, and we have had 7,000 or 8,000 more deaths in 2020 than we have ever had in the history of the state of Alabama. We have had more deaths than births ever, for the first time ever. Going back and looking from the beginning of the 20th century, we've never in the state of Alabama had more deaths and more births. But this past year, we've had about 8,000 more deaths than births, which equates to about the number of Alabamians that we lost. So I grew up in Talladega. If you're from East Alabama, you know where that is. That's a city of about 15,000 people. That's how many Alabamians have died in the past year and a half from COVID. My hometown would vanish off the map if we were all from there.
Those are some pretty startling statistics. One question from one of our faculty members is, why is the Alabama Department of Public Health so poorly funded? And what can we do about this? What advocacy can we bring to help this issue?
You all can help. Please talk to your legislature. I think state government funds the priorities that it hears from its constituents. We think we're doing our part. We try very hard and spend a lot of time asking for resources. And we have some people who are sympathetic and sometimes they're not. So please help us with that mission.
Okay, there's one question here that I think Dr. Frazier, we may need you to weigh in on. And that question is, please explain gain of function research and why are researchers trying to make zoonotic diseases like coronavirus more infectious in humans? What, any thoughts about that comment?
Oh, well, I'll be woefully unqualified to answer that. I understand the question, but exactly why those, and I'd probably yield to Dr. Harris and Casey, that it's certainly from an animal disease standpoint, research is often goes on, and it could be considered gain of function most any time when we're looking to just develop better ways of protecting those livestock herds and even our companion animals. That's the nature of research. And then those companies that invest in the mechanics of that will naturally be they funded it, they funded the research, and so obviously then there will be profit, but more than the profit of, I guess, financial return would be the security of our food supply, which is something that I'm really concerned about and watch closely. So that's, I guess, my only comments. I'm sure that is an issue it's in the news, but gain of function in my mind often when we're talking about animal research, that it goes on with an idea to really get that affordable, safe, wholesome protein to our families to be able to eat. Let me yield to the other panelists.
Thank you, Dr. Frazier. Anyone else like to respond to that comment?
I'll just add that the Department of Health and Human Services has issued a framework for guiding funding decisions around this type of research that's been out for several years. So I'd encourage you to check that out to learn a little bit more about it. It's outside of my focus area.
Okay, so our next question is, there's a myth that people of color are hesitant to take vaccine. However, it is my experience that their concern is around long-term effects and confusion over changing CDC protocols. How do we provide better and more consistent health education and reassure those with concerns about safety of vaccine without long-term data?
Listen, that's a terrific question. I don't think people of color have any more hesitation than others. It's certainly not in Alabama. You know, our experience has been that in a state where people lack access to care in many cases, you know, which is a longstanding problem in Alabama. There are many people that just have really smart questions about whether the vaccine's right for them, but they just have no one to ask. And, you know, if you have health insurance and you have a family physician you've seen for years and you want to know if your kids should get vaccinated, that's probably a 5-minute phone call to the nurse in the office and you've got your questions answered. But if you don't interact regularly with a healthcare system, if you live in a community where you don't even have healthcare providers, much less your own healthcare provider, really ordinary smart questions just can't be answered quickly or easily. And so people are left to sort out, all the mountains of misinformation that are out there. So, not all hesitancy is really hesitancy. Sometimes it's just people who can't get to a shot. We still see a lot of people who live in rural areas who have transportation challenges, who are concerned about the cost of the vaccine, even though, we all think that everyone knows the vaccine's free, but many people don't know that. And many people, haven't gotten that message yet. That's still a real challenge for us. And then, frankly, we're the state with the Tuskegee syphilis experiment. There's people that have, very good, reasons to doubt what state government is telling them in general, or what public health in particular is telling them. We, have earned that reputation and have to fix that a little bit at a time, as much as we can, by rebuilding that trust. And that just doesn't happen overnight, So on top of that is the whole national political divide that's just made everyone, mistrust the messages that they're hearing from people. So, the way that we address that is through trusted messengers. That's just almost sounds like a trope because we say it so often, but that's actually the answer. People will make good decisions if they get good information from someone that they trust. In most cases they do. And so, as I mentioned earlier today, we've tried really hard to reach out to local officials, to faith communities, to nonprofits, to any other organizations who can, get the message from us and put it in language that people understand and believe. And we'll continue to do that. The mad rush for vaccines that happened in December and January, we're never going to see that again. What we're going to see now is really hard work of getting 1 or 2 or 3 people at a time to overcome, whatever is keeping them from getting vaccinated and bring them in the door. And that's just not going to happen quickly.
That's a great point. I've been involved in several vaccine clinics here in Macon County, and we could get anywhere from 50 people. In some days, it's just 2 people. But we stand those clinics up anyway to make sure that access is available for those who are at readiness. The next question is, how can we begin the process of getting medical schools and physicians to include the inquiry of contact with animals or exotic animals during disease examinations?
I'll start off with that one. There's a lot of work sharing information with professional organizations such as the American Academy of Pediatrics or others about the importance of asking those types of questions for certain high-risk patients or when you suspect certain diagnoses. I think it's really important, especially during early education, that where there's universities, where there might be a vet school and a medical school or a public health university or some combination of those, for there to be cross conversations across those colleges as to what's important for the different students to learn. And this could be one of those topics.
Thank you. I think also, as we work with the city of Tuskegee, who was also a recipient of the Department of Health and Human Services Health Literacy Grant to roll out some of those messaging, some of those things can be critical pieces to add to the conversation and increase knowledge about what's happening, not just with COVID-19, but with public health in general. There's a question regarding, and Dr. Frazier, this might be for you. Is there any collaboration between State Department of Agriculture and the Tuskegee University or the Tuskegee City community concerning monies for community gardening? I think maybe Dr. Frazier has stepped away for a second.
I'm sorry, I got some issues with my bandwidth again. So, can you repeat the question?
The question is there any collaborations that you know of between the State Department of Agriculture and Tuskegee University or the city of Tuskegee or Macon County communities concerning monies for community gardening?
Monies for community, one more time. Gardening?
Yes.
Well, I do know that that here at our agency, we have a point of contact with USDA for small gardening and farming, and any connections or funds or projects that's coming from USDA. We do have a point of contact here. So when like Dr. Harris mentioned here at the department, our budget was severely cut maybe now 8 or 9 years ago, and we've never recovered from that either. And so we do not have enough funds to support projects like that. And so we're on the look constantly for small and specialty crop grants through the USDA. We would have to procure those from USDA. That may be directed to minorities. It may be directed again to specialty crops. USDA has some of those programs available, and the Commissioner of Agriculture, Commissioner Rick Pate, has a point person assigned that works on those type grants. We don't have those funds in our pocketbook at the department, so we have to look for them through our federal partnerships, and then we readily pass those out. We can help mitigate those, but to the recipients, but we will depend on and require assistance from USDA to help us with those kind of projects.
Thank you. So as I think I've tried, the chat kind of started moving pretty fast at one point. So I'm not sure if I caught everyone's question, but I do believe I did. And I know that I did interrupt you, Jotna, when you were trying to ask another one. Did you have another follow-up question before we close out this section?
Yes, I asked, and I don't know if you read the question, if we know what the false positive rates and then false negative rates for the PCR test for COVID is in Alabama, considering the current prevalence of the disease. I don't know if I spoke Russian or something. I can say it in simpler words. A false positive rate is the likelihood of you getting a positive test, a positive result when it's actually false, when you actually don't have the disease. And a false negative test is the chances that you get a negative result when you actually have the disease. And those things are affected by the prevalence of a disease. So the lower the prevalence of a disease, depending on how specific and how sensitive your test is, the lower the prevalence is, the higher the chances of you having a false positive. And the higher the prevalence of the disease, the higher the chance of getting a false negative. So it is a dynamic number though. So if your test is not sensitive enough or specific enough for the prevalence that you have, in the end, your chances of misclassifying somebody increase. So let's say, for example, to give an example, imagine that you are in a country in which nobody has COVID at all, zero. Tests have a normal degree of sensitivity and specificity. So that means that there will be some people on a test, because the tests are not perfect, some people will test positive when there is nothing. Of course, that means that the accuracy will be zero, but there will be a false positive rate that maybe, let's say, 1 in a million. If you have more people in the country that have COVID, then your false positive rate goes down. It's a complicated epidemiology thing. It's okay if nobody is.
Yes, but we are in a pandemic, aren't we? I mean, in terms of the infection rate is high, is considered high. So in relation to the PCR, it should be fairly accurate in that respect.
Yeah, I think, I lost a little bit of that. I'm sorry, my bandwidth isn't great, but I would just add, I mean, it's always true. If you test people at low risk for disease, you get more false positives. We understand that. But these are, highly sensitive and specific tests overall. There's just no way to divorce a lab test from a clinical evaluation. I mean, now you can go buy your own test in the drugstore and take it home and do it yourself. And, there's a place for that. But at the same time, we ought to have some sort of clinic. I would hope that you would have some sort of clinical evaluation. If you think that you have COVID and think that you might need a test, maybe test yourself. But, if you have access to a healthcare provider, that's there may be some interpretation required on your results. So You know, obviously, as we move into screening of populations like school kids, we are going to face some challenges if you're screening people that, you know, maybe aren't symptomatic and, you know, in some sense, maybe a somewhat lower risk for disease. But overall, we've tried to be consistent about who we think ought to be tested. And, you know, that guidance hasn't changed that much. You know, we want to test the right people we want to test the people that need to be tested.
To add to that, I know that the state requires that physicians order the test. And so adding that clinical piece to do the clinical observation and to do the questioning around symptomology is also a part of what we do to try to keep the phenomena that you're referring to, Jatna, at a very, very low frequency. The next question we have is, Dr. Harris, what collaborations are taking place or conversations across Alabama physicians concerning best practices and observations in treating COVID-19? And are there reports for the public?
You know, we you know, a large part of what we do is collaboration with our provider community in the state. You know, we have routine, you know, calls with various provider groups, particularly, you know, the medical association, you know, that sponsors a lot of those, but they include a lot of the different specialty groups, you know, under that umbrella. So we, you know, we talk directly to pediatricians, or we talk directly to family practitioners, or we talk directly to other specialty groups. We have a lot of subject matter experts that we've called on to help develop you know, guidelines about how do you treat people in the outpatient setting, how do you treat people in the inpatient setting, you know, how do you understand testing, you know, what are the indications for these products like monoclonal antibodies, you know, all that information is posted publicly. Most of it is on our own website, I believe, ADPH, but the Medical Association and the State Board of Medical Examiners is also publishing that information as well. You know, similarly, there are guidance in that vein that's been put out by our Nurses Association, by our Hospital Association, you know, other provider groups too, and all that's publicly available.
Got it. So I'm going to make this the last question for the panel. And we agree COVID-19 will not be the last pandemic. What will be the first or the most important thing each of your units will be doing when the next one arrives, given what we went through in this current pandemic? And we'll start with you, Dr. Behravesh, and then to Dr. Harris.
Sure. So one of the most important things we're doing based on lessons learned from the COVID-19 pandemic to date is formalizing our One Health coordination structure for the federal government. So we will have a platform to work together on routine One Health activities as well as One Health emergencies, and we'll have this formalized structure in place. So it won't be, you know, based on an individual's network or that sort of thing. And hopefully we'll be able to change the culture of how we work across sectors through doing so.
Thank you. Dr. Scott?
Yeah, you know, our you know, 3 goals throughout the pandemic have been to you know, prevent illness and prevent death, number 1, to protect our healthcare capacity, number 2, and then communicate effectively in a timely way with the public. That's our 3 strategies. We've, you know, done some better than others, but clearly we have challenges around communications that we just never anticipated. You know, I think we just naively believe that if we just told people the truth and what the science said, then they would believe it. And you know, clearly that's just laughable today. At one point, though, I think we actually believe that. And you know, ultimately, what we do in public health, you know, I mentioned earlier, our job is to advise. You know, it's not to decide, but really to put a finer point on it, our job is to change people's behavior. That's what we do. That's the tool that we have. You know, and in some cases, we're trying to change the behavior of, you know, really well-trained medical professionals who are providing frontline care by giving them the best science we can. And in many cases, we're trying to change the behavior of the public who, you know, is not medically literate perhaps and doesn't understand what all the fuss is about. And so clearly communications is something that we have really worked really hard to develop. Internally, we've learned how to coordinate with other agencies and others in the community on getting messages out and the right message to the right people. And I think that'll be a major focus, when, not if, but when we do this again.
Dr. Frazier.
Yes, thank you. So I agree and appreciate the comments from Dr. Behravesh and Dr. Harris. And we would look to participate and engage in this One Health talk and discussion and planning when USDA, CDC, and then coming to our state health department, when we can interface and interact with those 2 and 3 agencies. We are anxious to do that now. We want to, again, maintain what we have and what we've learned about diagnostics and how do we apply that to the animal health sector, and then advance from that and plan and train. We are looking for ways to enhance our veterinary diagnostic lab. Veterinary diagnostic labs actually ran COVID-19 tests for humans. So we want to look for ways to and planning in the future to enhance our diagnostic capabilities. But primarily from our standpoint would be to just engage with public health sectors, CDC, and through USDA at developing better ways to collaborate, communicate, as Dr. Harris pointed out, get correct information out. And underlying from my desk is that we understand and ensure the security of our food supply goes forward, whatever disease we face, or we will face more. My job is to help in secure and be sure that our food supply continues to be safe, affordable, and truthfully labeled.
Well, I would like to say thank you to all of you for participating in this panel. You have provided some very great information for not only our faculty, staff, and students, but also for our community participants. And we really appreciate you taking time out of your schedules today to be here with us. We will be continuing with our symposium during our lunch. It will be our Rural Health Lectures Series 4th annual Dr. Kenneth Oden lecture will take place, but we'll take a break at this point so that people can go and grab their bag lunches and we can come back for our session. So please use the morning link when you log back in for our luncheon speaker. And we'll be here waiting for you to come back and start promptly at 11:30 a.m. for that session. Before we go, I see there is one hand from one of our participants, and I think that's Dr. Abdallah want to remind me to remind you that you
survey.
we have a survey for this morning's session that has been placed in the chat. We ask that you all please take a moment. I promise it's really, really quick to fill that out. It does help us in planning for our future symposium. So thank you, Dr. Abdallah, for raising your hand and making that reminder. Dr. Nashar, is there any other announcements that we need to make before we dismiss our session for the lunch break?
Oh, thank you. No, I don't think so. However, Dr. Behravesh, she says, thank you, thanks to everyone, and she appreciated the great discussion. It was an honor to be part of this symposium. So thank you very much, Dr. Behravesh. Your contribution was really important. Thank you.
Absolutely, and we extend that to all of our panelists, as well as to Dr. Morris, Dr. Perry, and to Dr. Walensky, who brought us greetings this morning to get our day started off. I think this has been an awesome way to contextualize One Health for our students and to bring together all of our faculty and staff around the important issues that have been highlighted in using One Health strategies to address in emergency responses. So thank you again for your participation. And I look forward to seeing you all back here at 11:30 a.m.
Thank you all for your answers and for your patience. My questions. I know I can ask many.
No, thank you for asking great questions, Jotna. We appreciate that. So good afternoon and welcome back, everyone, to the continuation of our morning session of the 22nd One Health Annual Symposium. We are now getting ready to move into our Dr. Kenneth Oden lecture. And I just wanted to set some context as to who Dr. Oden is and why we have this lecture in his honor. We are pleased to present the 4th annual Kenneth Oden Lecture as a part of the Rural Health Lecture Series that was established by the Department of Graduate Public Health and the College of Veterinary Medicine. This lecture is held annually by the Department of Graduate Public Health and highlights a scholar and/or advocate in environmental health sciences that has or is currently conducting research and or advocating for advances that will help to decrease health disparities in rural and other marginalized communities. This lecture series, seeks to highlight faculty, policymakers, and community leaders that are trailblazers in this field, like the distinguished scholar for which it is named. Dr. Kenneth Oden was the director of the National Institute for Environmental Health Sciences, NIEHS, from 1991 to 2005, and the National Toxicology Program in the U.S. Department of Health and Human Services. He was the first African-American to become director of one of the NIH institutes, and in 2005, he resigned as director so he could devote full time to his research and position as chief of the metastasis group in the Laboratory of Molecular Carcinogenesis at NIEHS. He has also held the position of Yerby Visiting Professor at the Harvard School of Public Health for the academic year 2006-2007, and was the founding dean of the School of Public Health at the City University of New York from 2008 to 2020. From 2012 to 2026, Dr. Oden served as the director of the National Center for Environmental Assessment in the United States Environmental Protection Agency. He received a PhD in cell biology and biochemistry from Temple University in 1970 and is the recipient of 6 honorary doctorate degrees. He has a postdoctoral fellow and instructor in the physiology department of Harvard University Medical School in Boston from 1970 to 74, and also a researcher in the Laboratory of Molecular Biology in the National Cancer Institute of the NIH from 1974 to 79. He became the first African-American promoted to tenure with the rank of independent investigator at the NIH. And he also held several positions at Howard University Hospital in Washington, D.C., including director, professor, and chairman of the Department of Oncology. The long list of his honors and awards are included in the packet for you in the program. And I will turn it over to Dr. Nishar, who will introduce our distinguished lecturer for the 4th annual Kenneth Oden Lecture. Dr. Nishar, are you with us?
It's easy to forget. Okay, I'd like to welcome Dr. Graeme Lockerbie. He's actually a regular contributor to the College of Veterinary Medicine virology lectures. So I'm happy to see him again contributing into our symposium. Dr. Graeme Lockerbie is a director, Center of Environmental Studies of at the Urban-Rural Interface, and Clinton McClure Professor of Forestry, School of Forestry and Wildlife Sciences at Auburn University. He's a professor of the school in the School of Forestry and Wildlife Sciences at Auburn University. He also serves as the Clinton McClure Endowed professor in that school. He earned his Bachelor of Science and MS in Forestry at Clemson University and his PhD in Agronomy, Soils at Mississippi State University. Lokaby's program focuses mainly on the biogeochemistry of forested floodplains and relationship between wetlands and human health. In particular, his biogeochemistry studies have centered on decomposition and relationship between nutrient circulation in floodplains and net primary productivity. He has also studied the influence of altered hydrology and degraded water quality, as well as forest fragmentation and the incidence of West Nile. Notwithstanding his numerous publications, he has served as major professor for 32 graduate students and was asked to present the William Patrick Lectureship at a recent annual meeting of the Soil Science Society of America Wetland Soils Division. I'm pleased to welcome Dr. Lokaby.
Thank you very much, Dr. Nashar. I'm very pleased and extremely honored to be able to deliver the Kenneth Olden Lectureship today at here at Tuskegee. What I hope to do in this presentation is to discuss some of the intricacies that are associated with risk of a excuse me, of West Nile virus, which is a small disease in proportion to COVID, which we've been dealing with for years, a couple of years now. But the part of my purpose in presenting this topic is to demonstrate how different disciplines work together on very complicated causal factors. Something that's very, very critical and is trickier than meets the eye at first glance. So, could we advance the slide? I don't have. Oh, there we go. This is the West Nile virus life cycle, or some of the attributes of it. It's primarily associated with the genera Culex in mosquitoes, not exclusively, but Culex is heavily involved. And so Culex carries West Nile virus. They may transmit the disease to horses, but the horses are a dead-end host. A mosquito cannot bite a horse and become infected with West Nile. Mosquito can certainly transfer it to a human. We're primarily a dead-end host also, so a mosquito biting an infected human cannot become reinfected. However, one of the very complicating factors is that there is an amplifying host, a group of birds called corvids. I'm going to struggle during the presentation. You all can check me to say corvid for the birds instead of COVID, which we've all become so used to saying. A group of birds called corvids, which I'll talk about. Unfortunately, the amplifying host travels long distances, and so this is a key in the spread of the disease. Next slide, please. Again, this is not the magnitude of COVID. Human cases in the U.S. from 99 to 2019, about 52,000. Alabama, 366. Texas, large population there, about 5,600. There was a very severe outbreak around Houston, Texas, back a number of years ago. Deaths about 2,300. The mortality rate is about 4.5%. West Nile virus, the causes of the disease, the factors that facilitate the disease is very heavily linked to the environment and a number of other factors as well, which we'll talk about. This is a map of projections of population change, through 2050 in the southeastern United States. So West Nile is perpetuated when we convert natural cover, forest or natural cover, to urban cover. And I'll go into some of the reasons for that. But the bluer the images on the map indicate the greater population increases, the greener areas that might actually lose population. And so you can see that areas that are already heavily populated, heavily urbanized, Houston, Baton Rouge, New Orleans, around the Gulf Coast, most of Florida, up the Carolina coastline, certainly Atlanta, these areas are becoming more so, more urbanized. And so as Atlanta, for example, radiates out. and the greater metropolitan area of Atlanta, now extending into Tennessee, South Carolina, and Alabama. A number of environmental changes that occur that we'll talk about here in a second. Principally among these, it affects West Nile virus and probably some other diseases, zoonotic diseases as well, are the hydrologic changes that occur when we convert natural cover to urban cover. So if we look in the upper left-hand corner, we have a breakdown of the very simple hydrologic cycle of natural ground cover. We have about 40% evapotranspiration of the precipitation, 10% runoff, and about a total of 50% infiltration if you sum shallow and deep infiltration. So we move over to the upper right, and we go to about 10 to 20% impervious surface. That would be about the level we'd see in a suburb of concrete asphalt that has converted the natural surface, which is permeable to rainfall, to non-permeable impervious. And so at that conversion, we see an increase in runoff. We've gone from 10 to 20% runoff. Also, the velocity of that runoff is increasing. Infiltration has decreased from 50% to about 42%, and evapotranspiration has decreased. So we continue to develop, going to the lower left, about 35, 50% impervious. That would probably be about the level of impervious in the center of the Tuskegee campus, something like that. So again, our infiltration has dropped quite a bit now. We're on 35% infiltration. Much less water can get into the ground because it's cemented and asphalt over. Runoff up to 30%. And so again, the velocity is increasing there. And in an urban situation like 35, 50% and up, everything on the surface of that impervious surface is going with that water. So all sorts of bad stuff are going into streams, into stormwater overflows. So we continue to develop and pave, moving to the lower right, 75 to 100% impervious. This is about downtown Atlanta. So very, very heavily developed, very little infiltration here, total of 15% impervious, 55% runoff, and it is very high velocity associated with that. And again, it has a lot of energy to carry a number of substances, whatever it encounters, into the sewer systems, the stormwater systems, and into the streams. So next slide, please. One thing that we see when we convert forest cover, where you have a forest canopy that reduces the energy of the precipitation, the raindrops, to something that's more heavily developed, is we see that the discharge, the stream flow becomes very unstable. So if we look at the upper graph, the red line across there is stream flow or stream discharge. And you can see it's pretty much very flat. The dark line underneath that is the precipitation pattern for that forested situation. We call this a hydrograph. If we drop down to the lower graph, this is for a watershed that's about 40% impervious. And so this is what development does for us. Same pattern of rainfall, much more jagged red line. It means that the water comes down, flows off very rapidly. There's no slow infiltration through the soil to reduce the energy and deep percolation in the streams. It's all coming down, hitting the asphalt and cement, blasting off down the hill to wherever it can possibly go. This is why stormwater drainage is such a huge problem in urban situations. Next slide, please. This, I'm sad to say, is the definition of the issue associated with urbanization. This is a sewer fountain, sewage fountain. And so there's a design, engineering design in most of the cities in the eastern United States, which is very rapidly trying to be retrofitted, where the sewer system, the stormwater systems connect to the sewers. And so at times when there's a lot of rainfall and the stormwater systems can't handle the flow, they simply overflow into the sewers. And so this causes the sewers to overflow. This is a manhole cover that's blown off. And so what you see coming out there is literally very dilute sewage. In this case, it's flowing down to a stream. Now, this is where we get into some environmental justice issues because a lot of these sewer lines are associated with neighborhoods that are less influential in terms of financial resources. And so we get these streams. There's a number of problems, but I'll focus on the streams first, where you get dilute sewage in the water. And children being children, you know, we all, when we were children and even as adults, we like to play in water. And so we tend to let our pets get in the water. When they come out, you know, we give them a big hug. Children swimming in the water, fishing in the water. And so there's a very good chance of some type of zoonotic pathogen being transmitted associated with that. However, back to my topic of West Nile virus, when this overflows into the water and there becomes pools of this that are stable, non-flowing, this is a very ideal habitat for Culex mosquitoes. Next slide, please. So West Nile virus is complicated. And so to get at the risk factors, to define risk, you really have to look at a number of items simultaneously. So there's forest characteristics that come into play. There's that I'll talk about more in a moment. Urban hydrology, which we've already discussed. There's corvid habitat, which is a reservoir. That bird to the right is a robin, which is not a corvid. But the disease ecologist who worked on this project that I'm about to present referred to robins as flying bags of virus. And I can never forget that. I had always liked robins until he said that. And now I look at them a little differently. And socioeconomics, this disease is people who are in lower income strata are at greater risk for West Nile than people who are have greater financial resources. And again, more on that subsequently. And so Culex, interesting thing about Culex, it really likes very, very nutrient rich water to lay its eggs in. Some mosquitoes aren't like that. Not all mosquitoes are not that way, but Culex is associated with that. So we associate very good, very ideal mosquito breeding grounds, egg laying grounds for Culex associated with low water quality, very, very dirty water. So the more nutrients in there, the better. Those sewage overflows put a lot of nutrients in the water. In areas where the water is non-flowing, that's as good as it gets for Culex. Next slide, please. This was demonstrated back a decade or so ago by researchers at Emory University, where they were looking at the relationship between these combined stormwater sewer overflow locations and incidents of infected Culex mosquitoes. So this is a map from one of the publications there out of Emory. The dark triangles are locations of combined stormwater sewer overflows, and the kind of brownish cloud around those are where the abundance of Culex mosquitoes is highest. And so you can see a spatial correlation there. And so they were able to demonstrate a cause-effect relationship, which caused the city of Atlanta to spend billions with a B, of dollars to retrofit their stormwater and sewer systems to get away from this sewage fountain that I showed you earlier, because it was such a major driver of West Nile virus and some other diseases. Next slide, please. So coming on to our study, this is where the technique comes together with the team working together that becomes tricky. So we received our West Nile virus data from the Georgia Department of Public Health. Our study area is in Atlanta, in and around Atlanta. We require a lot of vegetation sampling. So we had people like myself, a friend of mine who's a forest ecologist, looking at forest structure, particularly what we speak of as forest fragmentation. That's when you go in and you have a forested landscape, and for some reason it could be urbanization, it could be tornado, hurricane, fire, whatever, fragments that continuous cover and puts it into small fragments of forest. That's very significant for West Nile virus, and again, more on that in a bit. Socioeconomic factors. If people who tend to be poor often may not be able to afford air conditioning, for example, and so leave their windows open at night during the summer because they obviously we can't stand the heat in a closed house, and the southeastern United States gets very hot. And so obviously that provides an entryway for mosquitoes. So that also, I'll give you a preview of where we're going. In the poorer neighborhoods in Atlanta, we sample the water there. I also do water quality analysis. And so the water quality tended to be lower in those neighborhoods. We think because the sewer infrastructure was older and dysfunctional. Sewer lines had more cracks in them. And so when you've got a situation where people have open windows, perhaps at night, and you've got lower water quality, dirtier water, that's setting up a bad recipe for West Nile virus risk. So we had a socioeconomist on the team. We had a climatologist who worked in climate modeling, relating our data, the West Nile data, to climate. And we had a satellite imagery person to look at satellite images for land use, land cover analysis. And we had a disease ecologist. Excuse me. So we had quite a diverse team in terms of expertise. And this becomes tricky. This is, I think, the techniques here are worth considering. You can say, okay, well, we need 6 types of expertise. We'll just go get them 1 through 6. Okay, and then you get the 6 people, and getting them to work in tandem can be a little tricky. They have to have the proper mindset where they're really interested. The whole is much bigger than the sum of the parts. And so if they understand that and have that desire, things work much better. But even with that, we left out one very critical piece of expertise that I'll mention as we go forward. Next slide, please. So we've got complicated mosquito breeding sites up on the left there, discarded tires. This has been a major breeding source location in places like New Orleans. They've attributed West Nile virus outbreaks, correlated it with discarded tires. We have a crow there in the middle, which is a corvid. And then on the right, dirty water. The water in Atlanta was very, very dirty in the streams. And so jump to an example to show you how dirty. When Katrina hit, on the CNN, it said, well, the fecal coliform count in the streets of New Orleans with the Katrina floodwaters was 15,000 colonies per 100 mil. During our sampling in Atlanta, we routinely noted levels of fecal coliform that were much higher than that. No hurricane, no catastrophe. Hate to put it this way, but it was just kind of the norm. And so very dirty water there. When that water is flowing, it's not much at risk for mosquito eggs, but in pools where it stops, that's when the risk is there. And then poverty down here on the lower photo with open windows and whatnot. So this is kind of the recipe. I guess the outmoded term would be the perfect storm, setting up for trouble with West Nile virus. Next slide, please. So I'm going to talk a lot about something called vector index. Excuse me one minute. Which is the average positive number of mosquitoes that are positive for West Nile virus collected per trap night. And again, we got these numbers from the Georgia Department of Public Health. Next slide, please. Our study area was in and around Atlanta. And so we in DeKalb and Cobb County, Fulton County, somewhat in Gwinnett. So this is the area we're looking at, very, very heavily urbanized, but we also got out into some of the, we didn't get into rural areas, but some of the suburbs that were a little lower in impervious surface than versus some of the others we had. Next slide, please. Some of our data, we had a lot of what we term lag effects in the data. In other words, if temperature was ideal for mosquito breeding, egg laying, it may be the impact of that on mosquitoes might be 2, 3, 4 weeks later. So here you can see average weekly climate data, temperature data in the upper graph, which seemed to peak in May and June. And if you look at the weekly mosquito abundance, it's the peak mosquito abundance is a little further to the right. So we see a lag between the ideal climatic conditions and mosquito abundance, which you would expect. Next slide, please. This is one of our interesting findings, and we're still not quite sure what's going on with this, but there was a correlation between, negative correlation between the proportion of pine species in forest patches. By patches, I mean just clumps of forest. And so we had all size clumps of forest from 1 hectare up to 100 hectares. And so the more pine were in these forests, there was a I'm not going to say cause effect, there was a correlation with lower West Nile virus index. Okay, next slide, please. This was I think our most solid finding, is a negative nonlinear relationship between patch size, going from 0 up to 60 hectares. These are clumps of forest, and they vary in size depending on where you are on the landscape, versus West Nile virus index. And so as you increase in patch size, the vector index declines. And we do believe that there's a ecological, biological reason for this. It's known in some literature as the dilution effect, which so many of you may be familiar with. And so this comes back to the birds, to the corvids. They tend to like fragmented landscapes, fragmented in terms of small forest patches. They thrive in that. When you get up to larger forest patches, there are fewer corvids. And so the chances of a mosquito encountering a corvid is much lower in a 40, 50 hectare forest patch than it is in a 5 hectare forest patch. And so that's what we think is going on here. That's what has been shown with ticks in the Northeast in relation to Lyme disease. So we believe this is an illustration of the dilution effect. Next slide, please. This was a positive correlation between pre-60, the number of pre-1960 homes, basically older homes, and the vector index. And so as the proportion of older homes goes up, so does the vector index. We think it's not so much the homes that are doing this, but the older infrastructure that goes along with it, the older sewer infrastructure, water lines. And so you get these leaky sewers. And again, in these poor neighborhoods, the older neighborhoods, the water quality tends to be lower. So that's what we think is going on with that. Next slide, please. This is a relationship between low-income households and West Nile. It's not an incredibly strong relationship. It is statistically significant, but as the proportion of low-income households increases, the vector index went up. The risk of West Nile virus increased as well. Next slide, please. These are cross-correlation maps looking more closely at the lag factor. And so on the upper left over here, the red color is indicative of a strong positive correlation, the blue indicative of a strong negative correlation. So for temperature versus vector index, we have a strong positive correlation. Surface moisture, moving one to the right, surface moisture versus vector index, strong negative. So as the moisture goes up, the West Nile virus incidence decreases. Down in the lower left, precipitation, we didn't get much of a relationship with precipitation versus vector index, but now moving one to the right on the lower group, very strong positive relationship between PET, PET, which is potential evapotranspiration, which is a measure that unites the influence of temperature and precipitation. So that one variable captured a strong positive correlation there. That was a weekly moving average, and you see similar results when you move over to the right for the 4 weeks moving average as well. So the lag effect very definitely operating there. Next slide, please. So our best model using stepwise regression included the percent pine in patches of forest, the low income, and the pre-1960s housing. Actually positive influence of low income pre-60 housing and a negative of the percent pine. And so this was a linear relationship, so it did not include that patch size emphasis linkage that we saw earlier, but the patch size linkage was our strongest single predictor. Next slide, please. So our conclusions: larger forest patches, which we think we know what's going on there, and higher pond composition, still kind of a mystery, are associated with lower lower West Nile virus risk. And so the larger forest patches, we convey this information to a group called Trees Atlanta and made them aware of it. And as I guessed, and as we would all guess, there are many factors in Atlanta that influence how large the patches of trees are: real estate values, a host of factors. So to the extent that anything can be done about that, at least we put that information in the hands of those who might have some influence. The second one is the percent impervious surface increases, the vector index increases as well. Not a surprise. Older neighborhoods and low-income households are associated with higher West Nile virus risk. Next slide, please. And then the lagged 4-week averages you saw there in the cross correlation maps. Number two, I would emphasize this. When we began to look at the different aspects of the causal factors, the socioeconomics, we didn't have as much detail there as, for example, the older houses. That was a socioeconomic variable. If we had had greater detail in exactly what it was about the older houses, I think it was that older sewer infrastructure, but it would be nice to have more detail there to zero in on actually what was the causal factors. And then the results, the final one here, reinforce the critical need for well-coordinated interdisciplinary studies. I think that's not a shock, not a surprise. I do think as we combat zoonotic diseases and emerging diseases, there'll be more call for this type of interaction, which, you know, the diversity, the expertise diversity in the team we assembled, I would suggest would be major. Sometimes the interdisciplinary linkage, the expertise is not so far apart, but there needs to be, I think, some careful thought about exactly how to link that. I think the team members need to be selected carefully so that they do have that mindset that, you know, that the study, the focus on a disease, we're going to learn a lot more if all of us work together. And it's not just about water quality alone, for example, it's about all the other things coming together. And also the data need to be collected in such a manner that they can be composited, combined, and analyzed in conjunction with each other. So those are some things to consider there. Next slide, please. So a favorable summary for West Nile virus: if you have urbanization on the upper left, followed by a warm winter, a wet early spring, dry late spring. Then on the lower left, the mosquito, QX mosquitoes, there's a blue jay in the middle, that is a corvid. And then people outdoors in the evenings, in which, you know, we're always going to have people outdoors in the evenings. And so that's just a function of the human race. We like to do things outdoors. And so those are the risk factors that we see. And again, some of the more detail there about forest fragment size and whatever the other variables. Next slide, please. We did a follow-up study. A master student, Nicole Castaneda, looked at some of the two findings that we had to see if we could delve in there more closely. Next slide, please. With the two conclusions that Nicole focused on was, are we correct about this dilution factor in the larger forest patches? So that was the first one. And then the higher pine composition. That was a surprise. Haven't met anybody who quite anticipated that one. So anyway, these were Nicole's goals, to delve into these two topics in more detail. Next slide, please. She established vegetation soil plots, went back and measured a number of the things that we did, including the socioeconomic data. But there was one really good addition. Next slide, please. We picked up that missing expertise that we needed from the team, the ornithology expertise. And so we sought help from Atlanta Audubon. And this is a fantastic group. I know some of you listening may be birders. I'm not. I learned that being a birder is not for people my age because people my age can't hear. So we would go out with these Atlanta Audubon teams before daylight. And there was a chemical engineer out of Georgia Tech who was phenomenal at this, but they're from all kind of different professions and backgrounds, but they love birds. And they could see very quickly a bird and hear its call and pretty much, and they would talk among themselves and say, okay, that was a such and such species. And, you know, I'm standing back there still wishing I could hear the bird call, which I could. I was the crow identifier. I was good at identifying crows. So Atlanta Audubon helped a great deal. Next slide, please. So the results from Nicole's work, which we're starting to get in publishable form. Bird diversity was negatively correlated to percent urban. So as the urban area increased, bird diversity dropped. And so that made sense because the small fragmented landscapes, the fragmented forest patches tended to have a lower number of bird species, but they tend to be corvids. Number of robins were correlated to percent grass. So again, percent grass is greater where there's more fragmentation. So the number of robins are higher there. Number of crows negatively correlated patch size. So in the big patches, there are not many crows. Crows are a corvid. Number of mosquitoes finally negatively correlated patch size. That's doesn't automatically suggest a reason, but I think we can get some insight into that in just a moment. Next slide, please. Have too many conclusions here, but I'll try to skip some of these. I'll skip down to number 2. Number of mosquitoes positive correlate to hardwood species for flight. And number 3, number of mosquitoes positively correlate to number of tree cavities. Okay, so pine don't have many tree cavities. Hardwoods do. when limbs break off, there tends to be a lot of internal rot in the hardwoods. These things fill up with water, and we think that those served as mosquito breeding sites. The 4th one, number of northern cardinals, which is a corvid, negatively correlated number of pine, and number of birds in general, negatively correlated number of pine. Next slide, please. So that was what we did with West Nile virus. I'll mention one other thing that's going through our minds that we're trying to get into and starting to get some work going with it, hurricanes and West Nile virus. So this is unfortunately one of the terrible photos of the areas inundated by Hurricane Ida in South Louisiana. Many scenes like this. This is merely one of them. Next slide, please. And so what we find with West Nile virus, or what others have found, I have not yet published on this, is that go back to Katrina, which hit in 2005. It doesn't seem that long ago, but it was. And so in the areas in 2005, immediately after Katrina, the areas affected by the hurricane, the areas unaffected by the hurricane. You can see in Louisiana, there's actually more cases per 100,000 incidents of West Nile virus was higher than unaffected, and just by chance lower in the affected. Some have conjectured this because the hurricane simply blows everything out, and so disrupts the environment totally. But a year later, this is where the lag comes in. A year after the hurricanes, the West Nile virus cases generally go up. And so after Katrina, they went up by a 2-to-1 margin. So you see in 06, in the affected areas affected by the hurricane, 4.4, unaffected in Louisiana, 1.5, down in Mississippi, affected in 06 was 6.5, and unaffected was 1.7. So next slide, please. The reasons that you usually read for why this has happened, and I'm sure both of these are, very valid and certainly causal factors. Increased human exposure. A lot of people just lose their homes, unfortunately. And so they're exposed to the elements more than they would be ordinarily. And then, of course, increased mosquito breeding opportunities. Much more flooding. So again, dirty water, like I mentioned, in the streets of New Orleans, the high fecal coliform count. And so again, this is a perfect recipe for corvid. I'm sorry, for QLEX. I'm getting all my C words mixed up. And so those two factors are probably very strong, but we think there might be a third one at play there. And so if we could go one more slide, please. What else does the hurricane do? It fragments the forests. So this is one of many illustrations. You can see upright trees, you can see down trees. And so it doesn't take this urbanization to fragment a forest. It can be something like a major storm, tropical storm, or hurricane. And so the net effect of that on breeding bird populations, some data coming in about that, but we hypothesize that if you have increased fragmentation, you might see a shift in the distribution of your bird species, increasing the potential for corvids to move in, which again is that amplifying host, which the QX mosquitoes need, the West Nile virus needs to continue its spread. So that's something there that we have in mind that seems interesting, and is if we look at the climate predictions, the climate change predictions, we're seeing seems that we're seeing a lot more hurricanes to me. I haven't been able to find a literature source that predicts more hurricanes, but there are some climate models predicting greater intensity of hurricanes, so they're going to be worse. And so possibly maybe greater frequency of hurricanes also. But this is not something that's going away. We have more and more hurricanes. We need to understand what the influence of those are as well on emerging zoonotic diseases. So with that, one more slide, please. Do I have any time for questions? If I do, I'll be glad to try to answer those.
Thank you very much, Dr. Lockerbie. Very interesting. There are actually some questions. If I may start first. We know that the mosquitoes are fed on horses. Is there any evidence that places where horses are populated, there is a transmission of West Nile virus?
The horses are said to be dead end hosts, and so all of you probably know a lot more about this than I do. I'm not trained in veterinary medicine, but that's what I've read, and so I guess I would raise the question: is that true? What I've read, that they're dead end hosts? I'm not sure whether that's correct or not.
Okay. What I meant is that is there an evidence that transmission of West Nile virus occurs, because obviously they feed on blood from horses, right. And you can feed in a human, and they may transmit the infection.
Right.
Okay.
I'm sorry.
Yeah.
There's some in the chat room here.
Okay, so there is a question: do the antiviral properties of pine have any relationship to the lower rates of West Nile virus?
Properties of pine, that's a very good question. I'm not sure, I'm not familiar if there are antiviral rates associated with pine. Could well be. If that's true, then that could be a huge reason why we found what we found. And so I would, if there are antiviral properties associated with pine, I would love to hear more about that. And so, yeah, please let me know, because that could shed a lot of light on some of what we're finding there.
The other question is, do people feed the birds in West Nile virus stricken areas?
I'm sure that they do. And so, inadvertently, just like, my impression of the robins, I had always thought those were very pleasant birds. I'm sure they still are. But people probably do feed birds and inadvertently draw in something. It may be a reservoir of West Nile virus, maybe draw them in closer to their homes where mosquitoes can then bite them. And so it's a hard sell. When we were collecting these data, people would come out from their homes and thank us for what we were doing, trying to understand West Nile virus a little bit, because there had been quite a few bits of mortality in Atlanta. And so that question is a very good one. Getting people to think about changing the layout of the forest on the landscape. In talking to Trees Atlanta, that proved to be a harder sell than I anticipated, just because I think, you know, in a huge urban area like Atlanta, it's just hard to manage the landscape. So much private property and so many interlinking properties. But yeah, I totally agree. That could definitely be a factor with people feeding birds there.
Okay, another question. Could health disparities in lower income communities be a factor in increased West Nile virus cases?
Absolutely, I think so. I think there's a very tight linkage between incidents of West Nile virus and lower income communities. And so health disparities there. One health disparity that we don't think about is that we talk to people in the lower income communities, and the type of information about West Nile virus was just not reaching them. There didn't seem to be much of an effort to reach those people, just to inform them that, you know, the West Nile virus incidence is high right now. You really need to use insect repellent, wear long sleeve shirts. And so they were very eager to hear these things, but there was an information gap in terms of outreach activities that did not seem to be reaching those folks. And so information is badly needed. And I think that should be targeted in these areas, the lower income communities that seem to be the most afflicted. Okay,
one last question. Do you expect these observations to hold the same for other mosquito-borne viruses? Do you test for other viruses in those mosquitoes?
It depends on the mosquito. The first question there, the Zika mosquitoes aren't like Culex. And they tend to breed in water. They don't particularly seek out polluted water. So I find that it varies a lot depending on, but they actually breed in vegetation quite a bit. And so it depends on the mosquito species and their ecological needs. So if there are other genera that tend to favor the polluted water, very definitely, but that's not an across the board application assumption can be made. And then we test for other viruses. The data we received was from Georgia Department of Public Health, and at that time our focus was West Nile, and those were the only data that we requested.
Okay, thank you very much. Okay, we will take a break from now until 1 p.m. And don't forget, we have very interesting afternoon session on ethical issues and vaccination, moderated by Dr. Ruben Warren. Thank you.
Also, you will need to log into the second link for the afternoon session to join that one. So please use the second link to join our One Health Cafe, which will focus on ethics and vaccination, which will begin at 1 o'clock. Thank you again so much for your participation this morning. I hope you've learned a lot of new things. I know I have, and I hope that it was informative for you in this space. We look forward to seeing you this afternoon.
Thank you.